Hi, I'm Dr. Herb Riemenschneider, urologist, Columbus, Ohio. I want to tell you about an exciting new development in the treatment of prostate cancer. High-intensity focused ultrasound, HIFU, and MRI are methods of 2017 and beyond to diagnose and treat significant early prostate cancer for cure. HIFU, with its sophisticated non-invasive characteristics, completely changes the way we think about prostate cancer. It is done in an ambulatory surgery center, no hospitalization, there's rapid recovery, and the patient and his family can dine at home or in a restaurant the evening of treatment. The patient is usually back to work within a week. Although the total prostate removal and total gland radiation is frequently done in large numbers in the United States, this will change. MRI and HIFU are non-invasive. There are almost no complications. There is rapid recovery and healing. When HIFU is done in young men, diagnosed early, with this treatment's precision, it is possible that conception and family creation can occur for involved couples. The video that follows will tell you the story of these amazing technologies, including examples that demonstrate how and why they are so successful. This may be the most important 20 minutes a man and his family can spend learning about this elegant treatment for a very commonly occurring disease of men. I'm confident that you will learn a great deal. I want to thank you for taking time to view this video. Prostate cancer is a very common event in a man, and we see this a lot. In some circumstances, there can be very benign changes that have appearance under the microscope of cancer, and there can be changes that are very assertive, and that's what we call grade, and we can go from a low grade to a high grade cancer. But we're also going to introduce a concept that you may be familiar with. It's called insignificant cancer. And there is such a thing, and as we go through this, we'll try to make that apparent to you. There's two areas here that really are hand in glove. One is imaging, and the other is a way of treatment without the traditional invasiveness that we think of the surgical scalpel. This is a profile of the prostate, and to this day, and through the history of my experience in urology, when we are studying the prostate to try to understand if there's a problem, such as a malignancy, we biopsy the organ. Now, as urologists, we're probably one of the last to do that. At one point, breast biopsies involved an approach where we biopsied the organ without a map, so to speak. But then we did get a map, and that's called a mammogram. And mammogram have led to other imaging, which include MRI. Well, the prostate has undergone a similar transformation. The MRI that gives us a picture, but there's a difference. If we take a CT or a CAT scan, which is a picture of an organ, for the most part, we're just looking at the shape, size, location, and what's around the organ. With the MRI, we can change what's going on in that organ with the use of magnetism, and we can alter the components of that organ, and then we can turn that magnet off, and it will generate a radio signal that can be ultimately converted into an image. And that's of great use. The question is, can we identify clinically significant cancer without having to remove the prostate? The answer without question is yes, we can. This is the part of the prostate that we're born with. We can think of that as the older component of the prostate. This has a name, it's called the transitional zone, and it's the younger component of the prostate, and there is growth in this area, and probably growth in this area as well, but this is more dominant and more characteristically identifiable. Now this is a similar situation, a prostate. This is an MRI, but as we look at it, somehow it looks different. But you can probably tell that there is an area here that isn't on the other image. Well, this is an anatomical type of image, a picture, but it's a picture that shouldn't be there. And the reason that it's dark has to do with its makeup of tissue in such a way that there is a restriction of movement within that area of water. Water moves freely most of the time. If I push this cup of coffee over, we'll be chasing it around the table or the floor or somewhere. But when things impair movement, the picture is altered. This, in combination with other findings, may be significant to tell us there's a problem in that location. It's called diffusion-weighted imaging. And this is telling us that there's something going on here that's different than normal. We want to hit a specific area in the prostate that we think has a problem. Well, we've shown you some of those things that give us those clues. So we're going to call that, just like you would call a target for your bow and arrow, a targeted biopsy. We're going after the areas where we think there is trouble. This is an article. This deals with a randomized study of 1,000 patients. And in that randomized study, there were two types of biopsies. There were targeted biopsies, and then there were mapping biopsies. The net of this study showed that the targeted biopsy demonstrated two things: a higher grade of malignancy, and it showed us where the malignancy was within the organ. With a targeted biopsy, we have a pretty good idea where we are and what we're dealing with. Now, this is a study that was reported at ASCO. This is the abbreviation for a large cancer organization that met in Chicago. So they are developing the understanding of how to interpret the pictures, the images that we get from a prostate that's not just well, but one that's sick. This is called a PI-RADS score. It's the way the radiologist who is skilled in looking at images of the prostate talk to one another, and they talk to us. If the type of changes in the cells that we find are those that are less aggressive, they tend to be on this side of the graph, and they tend to be some color other than red. If we find cells that are very aggressive in most of that tissue, they tend to be here, and we give that a score. So if we take the left side, that would be a PI-RADS 1, and the probability of a significant malignancy existing there does exist, but it's a low probability. On the other hand, if we take a PI-RADS 5, there's a good chance there would be more aggressive cells, very aggressive cells in this group, and there would be a much higher incidence of when this was carefully biopsied, targeted. We would find that information, and we would have a guide as to what kind of problem we're dealing with, and beyond that, possibly what to do about it. Now, the mapping biopsy, which is not guided by image, and biopsying essentially the same tissue, has a much lower yield of positive biopsy than when we use an MRI to give us a map. The negative predictive value ultimately, I think, will mean that biopsy will become much rarer than it is now. But let's just say this. At the moment, it's believed that in the United States there'll be roughly 1.3 million, and in Europe probably 1 million. There's reason to believe that 40 to 50% of those biopsies are probably unnecessary. Therefore, if you can analyze using MRI, you can pick out what you need to look at. Not only that, you can be much more precise as you select the tissue. Index lesion, what does that mean? Well, I was talking about significant cancer, and I mentioned insignificant cancer. An index lesion, we believe, has a certain characteristic. Part of it is determined by size. But some of the things that it does are not very well regulated. For instance, new growth of cells will generate new blood. That's called angiogenesis. And then there's other circumstances where cells will have a certain life cycle and then die. But there's some cells that are in what we call an index lesion that do not go through that process, and in so doing become the type of cell that continues to grow, dominates the prostate, and then can spread beyond the confines of the prostate. This is one system that the radiologists use after they do their analysis to communicate with us and their colleagues to tell us where they think trouble is in the prostate. The high probability of this being a significant lesion is accentuated so that it would draw our attention to this portion of the prostate. And this is how the radiologist and urologist become partners. Now, this is the apex, this is the base. In this particular case, we have a fairly aggressive lesion in the apex, and we have a fairly aggressive lesion in the base. So we could say we have two index lesions, and we have some insignificant cancer that under the microscope fulfills some of the characteristics of being bad cells, but doesn't have some of those growth characteristics that I was referring to with the index tumor. This is an MRI, and this is a lesion in the prostate that I think, now that I've talked to you about this, we all can see. With the teaching of urology, older portion of the prostate was always felt to be suspect, so that the biopsy mechanisms we had to get to these areas were predominantly designed to get here. But we would probably not be able to reach that area unless we knew it was there and we went after it, and we went after it with tools that would allow us to get there. Here's that same area, and this is one of those diffusion weighted images, so now we're getting some reinforcement for what we saw. And this is a situation where we actually give some contrast. Now, tumor cells require oxygen, they require more blood for nourishment, and they suck up this. And if you put certain types of contrast, in this case it's called gadolinium, in the blood, it's drawn to it like a magnet, and it lights up. So this is one of those things where we're taking a compilation of pieces of information, and we're coming up with a pretty good idea that we have a problem here, that if we just done a rectal exam, and maybe a PSA would have been a little bit elevated, it could have been very high, but maybe it was just a little bit elevated, and had we done a biopsy that we didn't know where to go with, we'd probably say to the individual involved, hey, your prostate's good, we'll see you next year. Well, now we know better, but right now I want to take another step. So what do we do about it? Well, I would say the norm in this community, and probably most of the communities around the United States, would be, Mr. Clark, your prostate's got to come out because you got a problem. And you know, they're not all wrong, because we would probably have biopsied this, found it to be an aggressive lesion in some sense of that word, and say, we can't just ignore it. However, there's a better way. Now, this is a magnifying glass, and is there anybody in this room who, in the course of their lives, didn't go out on a sunny day with a magnifying glass and start a leaf on fire, or fried an ant, or something like that? Well, that is exactly the principle of HIFU, except we don't use the sun. The energy we use, high intensity focused ultrasound. So we use ultrasound as the engine, and maybe we have 15 watts of ultrasound energy there. But as it goes through this lens system, this could well be 3,500 watts of heat that is produced at a point. Let's put that in a way so that we can guide where this energy goes. And we now are putting energy into the prostate, and let's just say that's a bad spot in the prostate. How in the world do we get enough energy into that area without ruining the rectum and damaging the tissue? We can just go back to our magnifying glass. And when the energy isn't focused, we could put our fingers right in the path of that energy, and it wasn't even warm. That is the principle that allows us to use ultrasound to be able to specifically identify a bad spot in the prostate, and we can destroy that bad spot. Now, if we do that, and we look carefully with the MRI, it may be we don't have to do anything else. This is really what it looks like. We call this non-invasive. In this system is not only an imaging ultrasound capability, but a transmitting capability to transmit heat to a particular area. And the thing that's unique about high-intensity focused ultrasound, or HIFU, is it's very precise. It doesn't damage the tissues around it. So you can go after the bad spot and leave the tissues that are not involved alone. The area near the shutoff valve, the area near the nerves that come around the prostate that allows people to be sexually competent, all of those things can be avoided. With early diagnosis, we can take out the bad spot in the prostate without damaging those other kinds of tissues. This is what we do when we're doing high-intensity focused ultrasound. We decide where we're going to put the heat, and we put the heat into these respective areas. And this is controlled by a computer. It's very dependent upon the patient being still and quiet. There is anesthesia involved. It has a lot to do with the operator understanding the physics that he is controlling. This is a gadolinium scan, and it's done on day 7. And this is what I was showing you before that was the bad spot in the prostate. What we've done here is we have destroyed that area of the prostate and the blood supply to it. And that's why it's dark under this circumstance. This is 180 days later. This really hasn't changed. This has healed some, but there was a bad spot in a prostate cancer there that is there no longer. The patient did not have disruption of his urinary control, did not have disruption of his sexual capabilities. The PSA was up at almost 7. It's now down significantly at 180 days and will very likely go lower. But remember, the reason the PSA didn't go to 0 is we didn't take the whole prostate and treat it. We treated a portion of the prostate. If you want to use the term, you could use focal. That's the reason the PSA doesn't go to 0, because we've got functioning prostate here. Now, let me make this point. There are fathers who've had prostate cancer of the type that I've shown you, been treated with the technology that I'm describing to you, who have fathered children, and the treatment of their prostate cancer did not make them sterile, did not take away their sexual capacities, and allowed them to be able to have a family. When we talk about preserving sexual capabilities, there are nerves and arteries that come along this aspect of the prostate. We call that the neurovascular bundle. We could treat right up to it and not damage the neurovascular bundle, which means that sexual function, urinary control, reproductive capacity stay intact. So this is nerve sparing. In other words, we can treat and not destroy tissue that we think is not involved and has value to the patient. I mentioned Dr. Emberton. He is really a preeminent researcher. This is Mark's study. There's 700 patients in this cohort. The thing that strikes me is these numbers are all very high, which means that the function was retained and cure. The continence, the sexual function, and the cure rates are all close to 100%. It's done as an outpatient procedure. These circumstances are absolutely accurate. You can eliminate disease. We don't alter the patient's ability to live successfully with the type of treatment that we've just talked about.